Oh, yeah, we don't need any more cortisol in our system, that we already, all of us have had, in addition to all the other things that have been going on in the world, including all the murders and all the everything. We need no more stress wars.
Yeah.
So you let us know when you want us to start.
I was going to say, how about on that note? How about on that note, we all just take a moment and we take a deep breath to calm our limbic systems or our amygdalas, or I'm not that kind of scientist, but we'll do a deep breath and then we'll start the session.
Sounds good.
So this is Dr. Sanchez. Just if anyone was looking for the NP fellowship program, I'm just going to include the link in the box as well in case you are here by accident or needed assistance finding the NP session.
Great. Well, we're really thankful that everybody's here. I'm incredibly excited for this session, creating a safe and welcoming environment for trans and gender non-binary patients, a training curriculum for healthcare security personnel. I think this is just such incredible and important work, and our field has done a lot to think about healthcare providers and improving the competency, but people don't get to the healthcare provider without interacting with public transportation and security staff and admin staff. And we know that it matters, but there's not a lot of work being done. So really, really excited to hear about this great work. I think it's really important work. And we have two fantastic presenters for you today. So Barbara Warren is a PsyD, the Senior Director for LGBT Programs and Policies at Mount Sinai Office of Diversity and Inclusion, where she leads the implementation of LGBT competent healthcare across the system. She holds an appointment as Assistant Professor of Medical Education at the ICANN School of Medicine at Mount Sinai, where she is teaching and developing curricula to address best practices in serving LGBTQI and other diverse patient populations. Dr. Warren previously served as a distinguished lecturer and director for the Center of LGBT Social Science and Public Policy at Hunter College, which is part of CUNY. And for 21 years, she was the senior management at the LGBT Community Center of New York. And she leads the center's behavioral health programs, co-founded the center's groundbreaking gender identity project, and led the center's health policy and government relations initiative. Dr. Warren has served as an advisor to local, state, and national government and policy organizations, and was recently appointed by HHS Secretary Azar to the National Advisory Council for Substance Abuse and Mental Health Services Administration. She's a longtime member of the World Professional Association of Transgender Health and holds a doctorate degree in counseling psychology, and is also a certified patient experience professional. And she's also been involved in the planning of this conference over the years. Barbara's a superstar, and we're really glad to have you here. And joining Barbara is Edgar Vargas, who is currently the Assistant Director of the LGBTQ Programs and Policies at the Office of Diversity and Inclusion at Mount Sinai. As the LGBT Program Manager, he works to expand diversity, equity, and inclusion across the system. Edgar facilitates training deliveries for healthcare providers, faculty, staff, and students, sharing best practices for engaging LGBTQ patients. Formerly, Edgar worked as a program manager for NDRI and focused on developing, adapting, and delivering training and technical assistance for substance use treatment and mental health organizations that are seeking to improve the adoption of evidence-based practices. There's a lot more here in Edgar's bio, a real superstar, but I don't want to keep taking up space talking about how great these folks are. You all can share additional points about your background, and then we'll let you lead us through this fantastic presentation, and we'll hold questions towards the end, but as they come up, feel free to put them in the chat. If the presenters want to take them at that moment, they can. Otherwise, we'll do it facilitated at the end of the talk. But with no further ado, please share your wonderful work with us.
Thank you so much, Jennifer, and thank you for the lovely introduction. Happy to be with all of you today. I think, Nelson, if I remember, I think I've been at every health workforce conference, or maybe I missed the very first one you did. No, I think I was at the very first one you did. So I don't know, what year are we in now? 8, 9, 10? I can't even remember.
9, 9, 10. Next year,
Nine,
everyone has.
all of them.
Next year, you have to wear a ball gown or
Okay.
tux.
Oh, next year I hope to wear a ball gown in person. In person. Thank you, everyone who joined today. And as Jennifer said, Edgar and I are excited to present this because when we first worked with our security staff at Mount Sinai, we actually were approached by them saying everybody else gets trained and we don't. And we have lots of folks coming in our system, particularly trans and folks, and we want to make sure we're doing the right thing. And Brian Dooley is on this slide. You'll see his name. He recently retired from Mount Sinai, but he was at Mount Sinai for 14 years as the training director at Mount Sinai for security personnel. You may not be aware that people in security personnel positions who are bonded and certified have to have CEs every year. They have to go through training. A lot of it is around security related issues, but we're also doing a lot of sort of cultural diversity and inclusion training with them. Now we're doing a lot of anti-racism work at Mount Sinai. And it is important to acknowledge that many of our security personnel most of them identify as men, and most of them are Black and brown people, although we do have some women. Brian was highly respected and was really, really an ally to us. And I just want to give him a shout out because he helped develop this training. And over a period of 18 months, we trained, we have about 500 security guards at Mount Sinai, and we trained pretty much every single one of them. And now we're coming up, it's been a year since we concluded this. We're coming up, I think, on the time to go back to our security leadership and say, do we need a refresher and how do you want to do that? And all of them, by the way, throughout the pandemic, were showing up in person. So they're really part of our frontline heroes because they took lots of risks by showing up in person at the front of all of our facilities at the height of the COVID pandemic infection rate. So Edgar, am I controlling? Oh, you're controlling the slide. So I'm going to let Edgar control the slides. We have no financial relationships. Next slide. Today, we're going to go over some best practices for our security personnel and interacting with and protecting transgender and non-binary patients, employees, and visitors. We're going to identify and deliver some of the training elements that will enable security personnel and other frontline staff to enhance the TGNB patient experience. And we did an evaluation. We did a pre and a post, and Edgar sort of carried that out and crunched the data, and he's going to present that to all of you at the end of this. Now, next. So there isn't a lot of research directly on the role of people specifically who are in a security position in a healthcare institution and how that role affects the patient experience. But there is a research that people on the front lines and how they interact, as Jennifer put it at the beginning, with patients coming through and visitors and employees coming through the front doors of any institution. Oftentimes, that's the first person anyone sees. And an environmental barrier, particularly for transgender non-binary patients, in terms of engaging in healthcare, can be all of those initial frontline experiences, all those environmental experiences, including how they get treated at the front door. Many of you know that most security guards are uniformed, and so they kind of look like, and some operate as surrogate police. And for many TGNB people and people of color in particular, these days, especially, we have heightened awareness of this. Interacting with anybody in a uniform like that can be a scary experience, even in the context of healthcare. So there is lots of support for how when folks interact with folks right from the get-go, in a way that is alienating or feels threatening, including being misgendered, and being able to use or document their appropriate names and pronouns. And oftentimes, with security, sometimes people are asked to show their IDs depending on where they're going. And particularly in COVID, people couldn't just walk through the front door anymore. They had to indicate who they were and where they were going. The idea that someone in a uniform might look at you askance or your ID doesn't match your appearance can be very, very threatening to TGNB people. So all the more is the reason that we needed to be able to enable our security personnel to treat people with respect and appropriately. This is what our system looks like. As I said, we directly employ, we used to outsource security. We don't anymore. Over the last few years, it's come in-house. They are our employees, which actually gives us a lot more control and gives us a lot more ability to support them. Of course, their job is to ensure, their primary job is safety and security across the system. But they also serve as customer representatives. And here's a picture of some of our actual security folks. And the reason that we wanted to show it to you is we took them out of police-like uniforms quite a while ago. And they all wear, whatever their gender identity is, they all wear the same garb. They all wear a black or blue blazer, khaki pants, a Mount Sinai tie, a white or blue shirt. So they're welcoming it. They're formally dressed and they have a security badge on them, but they're not dressed like they're police officers. So they also fulfill, they're trained not only to look out for safety and security, but they're also trained to welcome people, and they serve a concierge function, and are usually the first people that all employees, patients, and visitors will encounter in any of our sites. And most of them, I said, are male. Many of them are people of color, and they also have to be certified and insured to be employed in these positions, and they get annual CEs for that. And security supervisors and leadership, as I said, requested this training in response to security employees' requests for better tools and resources. So it really came from the employees themselves wanting to be able to do the right thing, the best thing. And that set us up, actually, to do training where there was very little resistance. In fact, it was very welcomed. And much to our surprise, that was one of our biases, or I'll claim it was one of my biases that I thought, we're going to come in and we're going to do this training. And we did it with Brian, who they trust. But even so, I'm going to come in and I'm going to be telling them this, and I'm going to see people with their arms folded across just why they're making us do this. And in fact, it really was the opposite. They were very glad to get the tools and the resources. They were very open. And they also liked the attention, if I can put it that way. Oftentimes they were left out of all of this stuff. And the fact that we were saying, you're important to the system, we need you, we want to give you the tools and the resources, we want to give you a chance to talk about some of your experiences. And you'll see, we talked not just about TGNB, but we talked about the whole issue of minority stress, and many of them identified with it in their own lives as well. Next slide. So what did we do in this training? Well, we had learning objectives that were similar to the ones we just shared with you today, getting everybody to understand who we were talking about some of the issues that TGNP people face in general in health, and then also giving them some opportunities to talk about their role, their job, and what are some of the things they could do. We have 3 case studies that we're going to share with you and see how you do on them that we presented to them. We also showed them the video of Vanessa Goes to the Doctor. Some of you have seen that. It's one that the National LGBT Cancer Network produced quite a few years ago under the wonderful tutelage of Liz Margulies, who has now retired from that. And it's being led by Dr. Scout. But I will say that that was really, really helpful because it sort of coalesced everything we have been talking about. We do talk about minority stress and microaggressions. And that was really important because it was something that many of them had experienced of themselves in their own lives. And so all of a sudden it wasn't like an us and them, us, the normal people, us, the security guards, and those weird people over there, that strange group, those transgender people, we don't really get them or whatever. It became all of us can identify with what it's like to be afraid that you might be treated badly or marginalized just based on how you appear or other people's perceptions of you. We went over the Mount Sinai policies, procedures, and the legal compliance issues. New York State has some of the strongest equal protections under law that are specific to LGBT people, particularly in public accommodations, names and pronouns, best practices, and the case studies. Next slide. Key gender terms, and I'll take a minute with this because we're just throwing this up here. Like, this is not necessarily exactly how we did it with them, but just to let you know, the trainings were about an hour. Oftentimes we got an hour and 15 minutes. We got 75 minutes, which was great. Because there was all kinds of shift changes, and Edgar can tell you this, it was kind of made us a little crazy because Edgar, Brian, and I did the training together. Sometimes all three of us were in the room. Sometimes it was Edgar and Brian or me and Brian. Brian was always there. And he led the case studies. And, we probably did, 30, 40, 50 trainings over an 18-month period because we wanted to get everybody in and we had to do a shift change. We also wanted to do it in smaller groups so people could discuss things and we had more time. In the key gender terms, the things that you see across the top, this was also an exercise that, and I don't know if we've ever shared this before, we use this a lot across a lot of our LGBT trainings, particularly our transgender and non-binary trainings. We talk about everybody, not just trans people. Everybody has an assigned sex at birth. Everybody has a gender identity, whether it's aligned with or not aligned with what you were told you were at birth, and everybody has gender expression. So we present this, and it's an exercise that we do with people, and we ask them, what's your assigned sex? How do you identify your gender identity? How do you express it? How do you express it in ways that people expect you to because they see you as a girl or a boy or a man or a woman? How does it differ for you? And we present gender diversity as a human spectrum, and we try to get people to understand that, again, we're moving away from the us and them, that we're all in this together, and that we all are on a gender spectrum. And it's a very powerful and effective way to get people not to otherize, and I put that in quotes, otherize trans and non-binary people, even if they mean well, towards people that are different. We put all humans on the spectrum, and it's very effective. And then we talk about some of the terminology, as you can see here, and we tell them words that we want to avoid. And again, we sort of tie this into everybody's gender identity is real to them, and really moving people to feel like we're all part of, a human spectrum. Next slide. We also purposefully address, and I see your thing, Nat, and we'll talk about that in a minute because we amazingly didn't get a lot of that. We only had one incident like that. Intersectionality and diversity. We do talk about this. This is not a course in cultural anthropology in any of our trainings, but we really want to bring home the fact that trans people have existed over time, across cultures, that it didn't just happen in the last 10 years, even though there's much more visibility these days, and that people identify in many, many different ways. And we talk about trans peoples from other cultures. This slide's a little cut off. We had many more names at the bottom of this slide than you can see here. And we show pictures. We show pictures of that some of you know, that is Zuni Indian at the top of the slide. That was Wiwa. She was Zuni. Today she might be called a trans woman or a two-spirit person. Picture dates back to the 1870s. Wilmer Broadmax, who was a famous gospel singer in the 40s and 50s, and it wasn't until after he died that it became public knowledge that in fact he was assigned female at birth. And then we have at the bottom two women of the Pacific, trans women of the Pacific Islands. It's a more modern picture. They are called Fa'afafine women. So we talk about people bringing their total selves to their experience at Mount Sinai, whether they're employees or patients or visitors, that are not just transgender, non-binary, like everybody brings all of their experiences So we point that out, and we say that we want to respect the total person and all of their identities. Next slide. And then we talk about names and pronouns. Now, you should know that security guards at Mount Sinai are trained to welcome everybody consistently in the same way. And we always said, so how do you welcome people? And they all say practically in unison, good morning, welcome to Mount Sinai. How may I be of assistance, or how may I help you? That is standard. They don't say sir, they don't say ma'am. We've really trained a lot of people out of using those gendered honorifics. And they don't normally ask people or address people by name unless there's some kind of instance where they need to know their name. And in that case, we have this sort of script that's here. And we say we avoid using Mr., Miss, Ma'am, Sir to ask first. Good morning, I'm security officer here. My name is James Jones. I use he and him pronouns. May I ask how you would like to be addressed? And that's pretty standard. That's what we're training people across the system to do. And this person said, well, my name is Ms. Charlene Smith. In that case, it's okay to use the honorific. Hi, Ms. Smith. How may I assist you today? And that is actually training that we're doing for anybody that comes into the system. Again, remember that for the most part, they don't necessarily need to interact on a personal level with everyone. But if they do and they have occasion, this is the way that we are encouraging people to speak. And for the most part, we've seen, we've tested it out, Secret Shopper, and we've seen that people are doing that. And putting little reminders up in the security cubicles as well. Next slide. This is the way we do the gender in 3 parts. Okay, so we were changing these slides at the last minute. This is the exercise that we do, and you can see the questions, that we ask people. And we spend some time processing this, and it really does help people to kind of see that we're all on a gender spectrum. Next slide. We give this handout. Now, I think this is really important. Now, this is New York, and I know many people, not everybody at the conference this year is from New York, but this comes from the Human Rights Commission in New York City, and this is actually their do's and don'ts, and we hand this out, and actually we found it hanging in their cubicles. We were very happy because some people throw it away, but when we went around, we saw in the security office or security cubicle, people had pinned this up. In a prominent position, which said that it came home to a lot of them that this is something that they wanted to be able to implement. And these are actionable. The offenses are actionable, and under New York City law, we could be fined up to $250,000 per incident, and in even more compensation to the patient if they brought a case against us with the Human Rights Commission. And we had some experiences with that in the past. Not, I'm happy to say, with any security personnel, but we always say to people, is this why we should be doing this? And most people will respond to us, no, we're doing it because it's the right thing to do. It's the right way to treat people. But we want people to see that it isn't just us saying this at Mount Sinai in our policies, and it's not just about being nice, it's actually a legal and regulatory requirement under human rights law in New York City and New York State. Next slide. And then we talk about the welcoming environment. And this slide always makes me, and you can see it's old because we don't have our 2020 LGBTQ Health Equality Leader sticker up there, which we are, I'm happy to say. And we also don't have our new Pride cling. Our new Pride cling has the new Pride flag, which has the pink, white, blue, black, and brown stripe on it, triangle on it, as well as the traditional rainbow colors. And it has it's Mount Sinai branded. It says all are welcome and all are included. And that's what's up now around the system. But I'm sad when I see this because a lot of the stuff that was ubiquitous across the system that we were handing out when we did trainings and had events are locked in, literally, folks, locked in the closet. Yes. Our Pride, visible Pride stuff are locked in a closet in our corporate office. And Edgar and I have been trying to mail stuff out to people. And we can't wait to get back and be handing this out and refreshing it in person. We do have all gender restrooms everywhere, and our security personnel are aware of it. And we sort of trained them in how to direct people to it as part of this training. Next slide. Here we are now. I'm looking at the time. Oh, good. We have plenty of time. We're at the case studies. Now, let me just say that all of these case studies came out of real life incidents. Brian and Edgar and I put them together. This was actually, case actually was a case that sort of sparked the security leadership coming to us and saying, look, we got to do some training here. I'm happy to say that that the experience of this case, there were two security officers that were involved in it, and they actually did the right thing. But they said, you know what, we really could use some support because this is happening a lot, and sometimes our folks aren't sure what to do about it. So what we're going to do now is, and you can, I don't know if people are muted or not, but I'm going to just read it out loud, and I'm going to ask you to put yourselves in the role of a security officer. And remember, if you're not trained in this, there are standard procedures they're supposed to follow. Think about that. And let me preface this by saying one thing. One thing I didn't say at the beginning. One of the things that Edgar and I and Brian all said when we first started the training is we acknowledged the fact that security guards, and this was a learning for me too, security officers, we call them, we don't call them guards, we call them officers and personnel, that security officers have a really tough job. They are supposed to, their main job is to keep everybody safe and to secure things and to keep the environment safe for all these people coming in and out of healthcare systems. And at the same time, they're supposed to do that in a way that is nice, that welcomes people, they're concierge, they have that dual function. And we acknowledge that was a tough role. That, on the one hand, they're supposed to be really nice and welcoming, but they're supposed to intervene if there's anything happening that threatens safety or security. So it's kind of like it's sort of paradoxical in a way. And we won't get into a whole discussion about how that's mirrored in some of the problems we're having with police these days. But in the context of security personnel in a healthcare setting, they're held accountable. They're not just held accountable for being welcoming, they're held accountable for keeping it safe. And sometimes those two things can be conflictual for them. So we acknowledge it was the tough job. We acknowledge that they were often underappreciated for that. And that really helped, I think, open folks up to this, what we were talking about in this training. So in this case study, remember this actually happened, and we would read it. You're called to a waiting area because two patients are having a loud argument. When you get there, the two patients are still fuming at each other. The front desk person who called you tells you that the patient in the red dress is really upset because the patient in the next seat said to the patient in the red dress in a loud voice, "You're really a man and you're disgraceful." And then they got into a loud, contentious argument over it. And there you are, you're the security guard. What do you do? So I'm just curious, I don't know if any of you have experience working in security, but what was the very first thing that you would need to do if you were a security guard? And you can throw it in the chat if you want, or you can just take yourself off mute and shout it out. Anybody have any idea? You know what security officers are charged to do in situations like that? Standard procedure.
I think one, maybe ensure that they're not, there's some physical distance between the parties. They're not too close.
You got it. The very first thing they need to do is to, what they call is to separate the two parties. And oftentimes they'll ask, would you mind, can you please stand over here? And would you go sit over there? And particularly the person who is if they can identify who the offender is. And in this case, it happened to be a woman who was yelling at another woman, and the other woman happened to be a person, as it turned out, of transgender identity. And so the woman that was, she was told that she needed to stop yelling, to sit down over there. And she was also told that if she didn't stop yelling, they were going to ask her to remove her from the waiting area. And the other woman was very upset. You need to do something. You need to arrest her. You need to, sometimes people don't understand that our security guards, our security personnel are not cops. And they tried to calm her down. And this happened to be an urgent care setting. So the next thing the security officer did, anybody want to guess what the next thing the security officer did? In this case, that we really applauded. We thought it was a really great way. Great thing to do. Nobody knows, huh? They have a hard job. They went to the woman who had been sort of verbally assaulted. He made an apology to her, said, "I'm so sorry that this happened. I understand that you're really upset. What we're going to do is you're waiting for an appointment. We're going to move you to the head of the line and expedite your appointment." And went up to the front desk, and the front desk was able to get the person back into the exam room. This was the woman of transgender experience. And then the other person finally quieted down, and the security went back to them and said, "Look, you have to understand we respect everybody here. It's really not okay to say things like that. And if you're not able to contain yourself, we're going to have to ask you to leave. But we don't want to do that because you have a right to be here as well and have your appointment. So do you think that you can just, calm down?" And the other person eventually said, "Yes, that's okay. I'm sorry," and all was well. And so when we presented this case, we actually got, immediately most of them knew they had to do a separate thing. And most of them said that it was absolutely it was not justified that anybody should be commenting on anybody else's appearance or saying anything like that. And they all agreed that expediting, and also what they did is they called in the patient experience. They went to the patient experience division, because we have one at every site. And the patient experience representative came down and asked the woman of transgender experience if she wanted to sit in with them after her appointment and file a complaint. And she did not. She felt like she was well cared for. She felt that she was protected by our security personnel. So that was the resolution of the case. And in talking about it, they all pretty much agreed that that was the best way to handle it. Next case. And this, doesn't happen as much anymore. We have gender neutral restrooms now. We have, and of course, in New York, you get to use the restroom that corresponds with your gender identity. We don't get as many complaints as we used to get, 8 or 9 years ago, but it still happens from time to time. A female patient complains to you, comes up to you as a security officer and says, "There's a man in a woman's restroom. There's a man in there. I just came out of there." What do you do? What do you think the appropriate response would be to this if you were security? Anyone? Nelson's answering it all, but anybody else want to say or put it in the chat?
I think it's, if you feel uncomfortable, please use the gender neutral bathroom.
Yes, in fact, excellent. That is exactly what we talk about. But of course, for security, how do they know that this is a woman's restroom? How do they know that there isn't? No, we're not talking about the patient didn't say, "Oh, there's a transgender person in the bathroom, get rid of them." They said, "There's a man in there." How does the security person know that there isn't a man in there sort of lurking in the stall somewhere? One of the things that basically most people said is you don't interfere. You keep your eye on that restroom to see who comes in and out. And even if a man does walk out of it, you knock on the door after they leave and you make sure there's nobody else in there, and you just leave it alone. Because and you check it out and you leave it alone. And for the most part, we don't really have this problem so much anymore. But yes, the very first thing is, here there's another restroom you can use. There's a gender neutral. All gender neutral restrooms are single stall. And that's exactly what we do. And in this one, there was an occasion where people would say, "Oh, maybe you should go in there and check." And we talked about, what the pros and cons of that were and how leaving the situation alone. And the few times it's actually happened, in fact, it was a trans woman that was coming out of there who was presenting as female. We don't ever hear it about the men's restrooms, right? And of course, we never hear any problems with the gender neutral restrooms or the single stall restrooms, but occasionally we were hearing it, but much, much less. And we have the signage that we use now in front of the restrooms is that this is all gender restroom. People are welcome to use the restroom, and most people these days don't. It's become much less of an issue. In fact, I don't think we've had a restroom complaint in a couple of years. And finally, the ID situation. And, Mount Sinai, like many of our institutions, we're not just a patient serving institution. We have a huge biomedical research institute. We do lots of conferences. We have lots of administrative offices. We have a medical school. And so oftentimes we'll get, and we have, corporate headquarters, we'll get visitors coming. And we have a new visitor new system now, actually, where people don't have to physically ask for a visitor. Where people get a visitor pass that they do through a kiosk. We had just started to install these kiosks. And so we did have an interesting experience with a person of trans identity whose ID didn't match her appearance and needed they usually take a picture of the badge of the ID. And instead they install cameras to take a current picture of the person, which was a really good solution. But in this case, you're asked to see identification to issue a visitor pass for a staff person to get to a professional meeting. The visitor is dressed in a suit and a tie, has a beard. They hand you an ID that says Dr. Susan Green on it with a female appearing photo. What do you do? And how do you think our security officers responded? They basically responded, "Thank you, Dr. Green. What floor are you going to?" "Oh, okay." If there was a doubt, and say, "What do you do if there's a doubt about that?" The doubt is, oftentimes they'll call upstairs anyway. They say, "Hi, let me just check that your meeting's still in the same room." And they'll call upstairs and they say, "I have a Dr. Susan Green here. Are you still meeting in 11A?" And, "Oh, yes, it's 11A, Dr. Green, go on up." That's a way to sort of check it without insulting the person. Recently, as I said, now that we're going to this kiosk system where we take a picture of someone's ID, if it's a trans person and how they're presenting, or any person and their picture doesn't really match their ID, they take a new photograph and they put the new photograph on there. And they handwrite the name because the old ID might say John Smith, but this person may be Jane Smith now. And oftentimes they'll say, "I see that you said you're Dr. Jane Smith. I see that your the ID that you showed me has a different name. Would you like me to create a new photograph for you and a handwritten ID so we can put your appropriate name on there?" And that's what we've been doing, where we've now installed the kiosks, which actually is in process now because COVID stopped that. But so, we had some lively things, and then they would present sometimes other situations that happened and discuss the best way to handle it. By the end of the training, there was a really actually nice feeling in the room and oftentimes I will tell you, somebody, Nat, you had asked a question about what do we do if people make jokes. We never had that happen. In part, Brian was in the room and he set the tone and talked about why it was important. At the beginning, we talked about their job. We talked about universal respect. We asked them, why do you think it's important to learn the stuff that you came here to learn today? And the security supervisors, many of them were older men. Many of them had been on the job for many, many years, the folks in the supervisory positions. And they kind of led the way. And we were pleasantly surprised. I was, it's my bias. I thought they would be the most resistant, and they'd seen it all, been there, done it all. Some of them are retired police officers or military people. That's how Brian got involved in this. And they really, and most of them were Black and brown. People don't show IDs if they're patients, Jennifer, coming in for a patient appointment. This is in the context of our administrative and bio research offices. That's where people have to show IDs. But people have to wear IDs if they are employees. Patients, of course, don't have to show IDs, but in other contexts, in other settings, in the school setting and in the research offices setting and the conference settings, people do have to come in with IDs because they can't get up into the floors where we do all the work unless they have IDs. Also, it's for safety. You know, our dean was shot a few years ago by a disgruntled employee. So not on campus, actually. He was shot on his way to work, but it really freaked a lot of people out. We realized we had to create a more secure space for our employees. And then I just want to answer Nat, and then I'm going to turn over to Edgar for the evaluation part of it. Like I said, one of the things when we do, we've had people make inappropriate remarks or jokes or say microaggressions during our trainings. And we'll stop the action and we'll say, why did you, we'll call it out in a way that, where did that come from? And oftentimes we'll ask the room, we'll ask the group, anybody want to comment on what you just heard and what you think about that? And the one time we did have, and Edgar can talk about his experience in a different room. One time I did have the experience of someone, having a real strong reaction to the man in the woman's bathroom thing and saying, I'm sorry, I would go in there. I wouldn't want my daughter in there with some weirdo and da, 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 da. I actually didn't have to say anything. Everybody else kind of jumped down his throat and said, hey, look, think about this. And then he kind of, I don't know how much we changed his mind, but he kind of said, hey, got to go along with the program. Okay, I see your point. And that really, it's training 500 people. That was the only time that I had that experience. We really tried to create an atmosphere of mutual respect and sharing best practices and acknowledging, again, some of the tough job that they had in their dual roles, and it seemed to work. And the minority stress thing, I think that people identified with in their own personal lives really rang true for a lot of people.
Right.
So,
if I may add, Barbara, one of the videos that we showed folks was, if you go to YouTube, there's a video called Mosquito Microaggressions. It's about 2 minutes or so. So that's the video that we actually showed participants at the beginning of the training. And a lot of folks were able to connect with that video in terms of their own, the experiences around microaggressions that they've experienced. And so that also helped set the tone for the PowerPoint presentation across.
And I'll be honest, that was something Edgar did when he co-led with Brian, and I didn't integrate it into the training, but now we would revise and update this training because we'll do a refresher and we'll train some new security people. And we would certainly use the microaggression video because everybody can identify with that.
Right. So, with regards to the some of the demographics with regards to the surveys that we did. So we did train over 500 security personnel, and we had approximately 283 participants. So a little bit over half, a little bit over 50% of folks who completed both pre and post surveys, right? And so again, for reasons that Barbara mentioned, we were intentional on not collecting data around ethnicity, race and ethnicity, and also sex. And then Cami, I'm seeing your comment. So the video is titled Mosquito Microaggressions. And if you go to YouTube and just type that in, it's the first thing that comes up, right? We can drop the link in the chat later. So with regards to the survey itself, again, we were intentional in not collecting data around race or ethnicity and sex. Barbara mentioned that most of the folks, most of the security personnel are Black and brown men, mostly lower income folks, and the majority, as you see here, the majority of them also had a range of different time working as a security officer or in a security field. As Barbara mentioned, some of our security personnel were also previous military folks, right? And police officers around the New York City area. And then if you look at the left side of the slide here, we also did collect data around education level, right? And so the majority of folks had at least a high school or equivalent degree or completion. And then about 21% or so, or 22% had a bachelor's degree. And so folks are educated. And then when we focused on the survey itself, I just want to go back. We did, again, we were intentional with the questions that we were asking folks. We did ask questions around attitudes towards transgender and gender non-binary folks, specifically 8 questions that we asked, and then 4 questions were more practice and operational and practice oriented. And again, we did collect the first and last name, a date of birth as a way to match up the survey. But again, as Barbara mentioned early on, we were surprised that the majority of folks were generally, that was the bias that we were expecting for folks to be a little bit resistant or not to be sort of like, okay with the presentations that we were going to be doing. But, we were shocked, in a positive way to learn that that was not the case as much, right? As you see here from the first question, I am always comfortable greeting and welcoming transgender and gender non-binary patients and visitors to Mount Sinai. So before the training, 82% of folks agreed, and then after the training, 88% folks agreed. So that went up slightly. When you focus on the second question, I am familiar with transgender and gender non-binary terms and identities. That did go up. That was a significant increase. Again, 55% before, and then 78 after the trainings that we did. And then the third question, and again, these questions are where we saw, I think, some of the most notable differences to an extent, or things that surprised us at least, right? The third question being, I know what the Mount Sinai policies are around grading or assisting transgender and gender non-binary patients, employees, and visitors. So again, that went from 68 to 90% after the training. And then the last question, again, that was a bit of a shock for us in terms of, folks were comfortable before the training, working with and engaging with transgender and gender non-binary individuals, and working for a company that welcomes transgender individuals as well. So these were the results. Again, we were pleasantly surprised to find that there wasn't a lot of resistance or bias from participants who went through the training. Barbara, is there something that you'd like to add?
Yeah, I just want to say, we have a tendency to forego these days when we do these surveys, and we try to do some of it, and it's an evaluation survey. It's not rigorous quantitative research or even rigorous qualitative research, right? But we like to get people's comments after, and we did we got a lot of comments after about that they enjoyed the training, that they thought it was important, that they learned valuable stuff. They wanted more of it. They wanted longer trainings. We talked about unconscious bias and some of the work we did around that. They wanted those trainings too. But I think the thing that I've learned in these surveys, and if you go back, Edgar, to the original question, can you go back? I don't know if other people have had this experience doing evaluations to the questions. Yeah, we pulled the attitude questions off some other existing surveys that were valid surveys, were validated. And we expected to get maybe answers that would show that there was some prejudice or bias there. And in fact, we didn't, and I don't know if that's because this is New York and people have already been exposed to it. We do ask a question: how many of you have interacted with a transgender or non-binary patient, employee, or visitor so far in your work here? And almost all hands went up. And how many of you have someone in your life you care about who's of transgender or non-binary experience, whoever that might be? And about half the room raised their hands. So obviously, this is New York. We're talking to probably a more exposed and more sophisticated group of people. I don't know if you get the same attitude answers, positive attitude answers, if you did this in other parts of the country. And that would be an interesting thing to find out. So we didn't really get any variability there. And whether or not it was because they really believed that a person who's not sure about being male or female isn't mentally ill, or if they knew what the socially acceptable answer was, those questions didn't really work for us. We would redo this evaluation differently the next time that we do this. The one thing but it gave people things to think about as well. So I just wanted to sort of point that out. And the operational questions are where we got the increases. So we're happy to see that it mattered to people, but we're also happy to see that they felt like they learned something through this training. So Again, what did we learn? Expecting resistance from security officers based on trainer bias. Both Edgar and I had to admit we had it. And it was a learning curve for us. The importance of including the security managers in the training and particularly Brian, who was a highly respected, highly regarded a leader and training director who helped develop the training and deliver the training. Again, acknowledging the challenges of security role within a healthcare system, a sort of dual role that sometimes feels conflictual to folks. Ensuring that our training offered their continuing education credits in the annual recertification process. Not only did they have to sit through it, we also gave them goodies. We gave them, we had these wonderful rainbow gel pens and different items. We have a lot of we were able to do this in person because we completed it right before COVID. And they loved getting the little prizes and the little pride stuff. And they asked for more. We always brought extras so they could take it home to their families and kids. The scheduling issues, the way we scheduled it, Edgar and I and Brian, we were available around the clock, and we did it so that they were coming during shift change, and they didn't feel like they had coverage, and they didn't feel like they were doing extra hours. And then again, this idea that, frontline staff oftentimes, and particularly, folks who are doing things like security or transport, I've gone down into the bowels of some of our hospitals, into the kitchens, wearing a hairnet and training the people that were cooking the food and cleaning the pots and pans and doing, enhancing the transgender experience or LGBT stuff and inviting them to participate in our employee resource groups. And people really appreciate that. And too often, as I think Jennifer said at the beginning, we do focus on the healthcare delivery staff, the people who have, the clinical roles and even some of the front desk staff, but there's lots of other people. There's transport people, there's housekeeping people that interact with patients all the time. And at Mount Sinai, we've really, really been paying attention to and focusing and acknowledging the importance of their role in our patient and visitor and employee experience. So those are the lessons learned through us doing this. Did you want to add anything, Edgar?
Sorry, there's so many screens. I'm trying to find the. But no, I think we cover that, everything for the most part. So I guess at this point we can open it up to questions.
And by the way, Edgar's standing there with a couple of our leadership, our security leadership, the director of security for the system, and Brian in the blue shirt. There he is, and now he's retired. And another leader in security. I don't know all of those guys. I know that the head of security for Mount Sinai is the gentleman all the way on the left. So there we are. So any questions or things or comments that people have? We have, what do we have, 5 minutes? Yeah, we have about 5 minutes left.
First of all, thank you so much for this work and for the presentation. Really, really powerful and really great.
Thank you.
I think, like you mentioned, we often focus on clinicians and don't get around to everyone else, all other staff members, either because limited resources or time or dedicated resources. There's Edgar at the institution. Are there people within security that you could potentially pass this off to, or train the trainer material so it's not falling on one or two people all the time? And kind of what people can learn at their own institutions. Sometimes people feel like, oh, I'm the one doing everything. At what point can I offload this to someone else? But you also want to maintain quality control. How do you navigate that?
Yeah, it's challenging actually, Nelson. That's a good question. We worked with Brian, and the idea always is to try, and we've been doing this more and more, sort of doing train the trainer stuff with other people. It is, Edgar and I, it is our job. We also have a diversity, equity, inclusion division we have 25, 28 people now, and the other people in our division who are experienced diversity trainers do include LGBT content in most of the work that they do. We're doing that more and more integrated content our anti-racism work has an LGBT component, or LGBT work has an anti-racism component. Sometimes we found, we've done some train-the-trainer stuff, and sometimes we found that, we trained all of our patient experience professionals in enhancing the transgender patient experience, our core training, our sort of core generic training. And that was about 30 of them. And then we had turnover, and then we had to retrain. So we're always involved to some extent. With this one, it was so sensitive, and Edgar and I really know how to, we're good. We have good training facilitation skills, as well as content knowledge. And so we decided that we would do it with. And so, yeah, there's a little bit, it is challenging that way. And it depends. It depends who we've had cisgender, heterosexual folks who were great allies and were really good at this training. And then sometimes we've tried to get people with lived experience to do the training. And they either didn't want to do it, or just because they've lived experience doesn't mean they're great teachers or facilitators, even if they understand the issues. So, and sometimes it's triggering for people with lived experience. They have to deal with, what people say, but it's always triggering for me and Edgar anyway, but we know how to deal with that. The other thing is, I saw a question about how do we get leadership? And I think I mentioned at the beginning, the head of security came to us and asked us to develop this training. Because they had a couple of incidents, and their security officers came to them and said, hey, look, we think we handled this all right, but we need some training on this. We really have a culture and a climate of that at Mount Sinai. And I have to say, we're not perfect, obviously. There's lots of problems that we encounter around our DEI work. But I because we're in New York, because we have a Center for Transgender Medicine and Surgery, because we have thousands of queer people coming through our doors all the time, because I've been heading up this work at Mount Sinai for 9 years now. I think people come to us and say, hey, we need this, we need that. So we have a lot of collaboration and cooperation around all the queer related work that we do there. And it's also our top leadership. It's like, there's no question about it. It's like that, and the fact that I think 3 out of 8 hospital presidents are openly queer identified, which also helps. Any other questions or looking in the chat? If anybody wants, yes, and you're right that it may not happen that way in a Southern institution. But sometimes if you go, if any of you are in a Southern institution and you feel like it would be helpful to security, go to whoever the head of your security is there, or strike up a conversation, or do a needs assessment and say, we just want to find out if our security officers here, particularly in a lot of places it's outsourced, so that can be problematic too. But if it's not, or if your security leadership, even if they outsource the actual officers, if your leadership there isn't, to have a conversation about it, and to say, this is something, and we're happy to share the curriculum too. If you want to adapt it to your own institution, we'll be happy to share it.
Barbara, can I ask a question?
Oh, go ahead, Juan.
I'm sorry. This is Juan Mejia from New York Presbyterian Hospital. First of all, this is great. I may actually reach out to see if we can borrow some of this just as additional training for our security officers across our campuses. The specific question that I have is, can you elaborate further on the training, or what the training looks like for the security officers around the ID, and if the individual's picture doesn't match them? As you know, security sensitivity is really important, especially I'm thinking of security sensitive areas like the Well Baby Nursery, the NICU. So what does the training look like to make sure that the officers are responding appropriately when the picture doesn't match the individual?
Well, again, what we do in that last instance is we talk about that situation. Again, a patient's coming in. We're in a transition now at Mount Sinai, because we're going to go to this kiosk system, right? And the kiosks are going to be in certain places and not in other places because we don't want to impede patients coming in and out. And I'm not sure how they're going to resolve that. Where there's a kiosk, and it's generally in places that are more like the Research Institute, the medical school entrances, the biomedical research, the administrative offices, places like that, that you do have to have either an employee ID to get into, or you have to have a visitor pass. That's where they're putting the kiosks right now, and for those kiosks, you have to if you don't you can use your badge, but if you're not an employee, you have to get the visitor pass. And like I said, what they were doing was they were just taking a picture of your ID, and that would become your visitor pass that you would wear here, and they would give you a pass to get through the kiosk. And instead now what they've done is they've installed cameras, so they take a picture. This is what recently came up when we had a trans woman whose ID was still her old ID, and she didn't have anything yet that, and she said, I'm not walking around with a man's name and a man's picture on my chest. And they resolved it by taking a new picture of her and handwriting in her current name. And she was allowed to wear that there. And they told her, if anybody questions you about it, they can call down to the security desk. And that was a fine solution. And that they actually created a policy around that they sent out around all of Mount Sinai to all the security officers or security supervisors to share where the visitors' passes were required. So that, I hope that answered your question.
Yes, thank you.
So we've reached our time for this session. So let's just give a round of applause to our fantastic presenters, and by my little clapping hands, there we go. And then